So, pediatric patients. The problem with these guys is preoperative fasting. It's not really a good idea with them. They can get very hypoglycemic, so their blood sugar can drop, and dehydrated. You want to keep in mind giving them 5% dextrose in fluids during the procedure and administer at a rate of 5 mils per kg per hour to prevent overheat hydration. So we often use the 10 mil per kg per hour rate as a general surgery rule, but you want to cut that in half for these guys. And you also want to use that smaller drip set like the ones used for kitty cats. Otherwise, you can also overdo it. Use a gram scale. Get an accurate weight on them. Otherwise, it's very easy to overdose them. Dilute injectable agents. That way, things work a little bit smoother. Avoid agents requiring liver metabolism in animals less than 8 weeks. They are very prone to hypothermia. And intubation and IV catheterization can be very difficult. So you have to be prepared, have your equipment, know what you're doing, hopefully, or have somebody there who has some experience. Also, you're going to want to pay attention, if you can't do the 5% dextrose or you're having catheter issues. I have in quick situations, especially like spay-neuter clinics, things like that, you've used corn syrup or something like that on their gums to try to get some sugar into them. Brachiocephalic, we've talked about these a little bit already, but they have their anatomic abnormalities. Make sure you can list all of those problems, okay? If not, pause and list them out. Anesthetic agents that depress respirations or reduce muscle tone in the pharyngeal area, so that can make these guys very dyspneic. They'll have problems breathing. High parasympathetic tone can cause bradycardia. And don't forget their pharyngeal area, due to all the extended palates and everted saccules, etc., can be prone to swelling. So it can take just a little bit of intubation to cause it to swell, if you're back there whacking it with the tube, or if they're excited, panting, and after surgery. You have to be really careful about that area swelling when you extubate. So solutions, we try to pre-oxygenate for a good 5 minutes before induction, whether that's with a mask or just flow by. Induce them as quickly. This does not mean slam in the propofol, just be efficient. Use a laryngoscope, so that way you can get it in one and done. You also hopefully don't cause any trauma. You may need a smaller ET tube than you think. And then after anesthesia, leave the tube in place as long as possible. These patients tend to have airway obstruction even after their sternal. Again, things will start to swell. So you pretty much want them to be about to eat that tube in half before you extubate them. Deliver oxygen until extubated. Again, even if it's not connected to the tube, try to keep them on flow by to help get them as well oxygenated, or put them in a mask. After extubation, monitor them for a while, keep them quiet, reduce stress so that way things don't swell. Sight hounds. So these are like your greyhound, Saluki, Afghan hound, Whippet. These guys have a sensitivity to thiobarbiturates. They don't have much body fat, so that changes the redistribute of drugs. So you want to think about that. They may be very heavy, but it's all muscle, okay? They do not have great liver metabolism, and they are very prone to hypothermia. Again, no fat. So even if they're heavy, because they're large animals, they don't have much that helps to kind of buffer them against anesthetic drugs. So obese patients, these are on the opposite end. The blood supply to fat is poor, so their drugs are not effectively redistributed to the fat stores. Okay. Respiratory difficulty can be common. Their breaths, they'll get hypercapnic, rapid shallow breaths. They'll have a difficult time pushing out that CO2. So their solutions, their dose should be based more on their lean weight. So just because, you have a little dog and it's, you can tell it's like 10 pounds over, you might want to base it on a leaner weight. Pre-oxygenate again before induction to make sure they have plenty of oxygen on board. And you may need to bag them until they're taking nice deep breaths, or if they never take nice deep breaths, don't forget you can give them good breaths to make sure that everything's circulating properly. C-section patients. Okay, so these guys have a whole bunch of stuff besides the fact you're trying to get those babies out as fast as possible. Aspiration's an issue. These animals are not fasted. This isn't usually an emergency. And you are slowing down their digestive transit by doing putting them under anesthesia. And so there's a good chance that they may regurgitate at some point during the procedure. So you have to make sure they don't aspirate, and if they do start to vomit, that you clear it. Their decreased lung capacity. So they have puppies pushing on their lungs. They can't take big, deep breaths, which also decreases their tidal volume. Okay. Increased oxygen demand. It's not just them, but all those little parasites are in there taking their oxygen. Increased cardiac workload. Their blood flow, they have I think it's 30% more blood is what happens when pregnancy occurs. So their heart is working harder. They'll be most likely anemic. Again, because they're trying to oxygenate for everyone. Their blood pressure is poorly regulated, and they're prone to hypotension, and they'll end up having a decreased anesthetic requirement based on how the progesterone in their body that's maintaining the pregnancy has effects on GABA. You have to be careful because anesthetic drugs can cross the placenta and affect the fetuses, and they have a high risk of shock. So in this case, you want to prepare the patient before anesthetizing. Get them as clipped, prepped, and so that way you're doing as little as possible with them on the table. Anesthetic protocols can vary. Most vets have their own preference. You may want to try an epidural with a tranquilizer or some kind of neuroleptal analgesia, so that way you're using much less inhalant. Maybe you don't even need to put them on something like ISO. You can do it more of a drug. Lower dose of injectable anesthetics plus inhalants. Opioids, which are reversible, so if you start having problems, you can reverse them. You want to avoid diazepam because of how it can affect the fetuses, and avoid any drugs that significantly lower blood pressure. And pre-oxygenate. They're already having difficulty. Make sure they have plenty of oxygen. Try agents that decrease vomiting, or put something on to help them decrease vomiting. Quick induction, so ideally not by masking them. You want to get them induced and intubated as quickly as possible. You may want to go larger with your catheter size, or put 2 catheters on, so that way you have plenty of venous access, fluid support, and in case you need to also get drugs into them quicker. Post-op analgesics are obviously a must and do not affect the nursing neonates. The neonates, you're also being prepared for them, and ideally you have all of this laid out before you start the surgery again. They may need oxygen. You may need to intubate with an IV catheter and bag them if necessary. Remove fluids from the oropharynx. So that's, you've seen everyone shake them. Also just trying to swap their mouths out, getting any mucus or whatever from their mouth. Potentially reversal agents. So if a little opioid slows them down, you can reverse that. Doxapram, you can give 1 to 2 drops of that under their tongue. You can give them a little atropine if they're bradycardic, and get them to nurse as soon as possible. Monitor closely if the mother is still recovering. And you can bottle them if you have to, just to get a little bit of something in them, because that's your goal, is to get a little bit of milk in them. But ideally, they get them to actually nurse with mom. So, trauma patients. All sorts of problems with these guys, depending on the trauma. Well, they may have respiratory difficulties, so if they have a pneumothorax or lung contusions, if they're hemorrhaging, or diaphragmatic hernia, all that will make them unable to breathe normally. Blood pressure changes due to hemorrhaging, sequestration of fluid. They could be in shock. Any kind of internal injuries, including fractures, etc. Also, so you can see this guy. Oops. You can see that he obviously is having respiratory issues. You can see that weird wave of oxygen. This one as well. They're trying to pre-oxygenate. So how do you deal with these problems? The first is, before you put them in anesthesia, you want to try to treat or at least manage these respiratory issues. So some kind of thoracocentesis, that's if there's any fluid or air on the chest. Remove that, because that is inhibiting them from taking normal breaths. You may need a diuretic if the fluid is within the lung itself versus around the lung. Keep in mind that cardiac arrhythmias are a common sequela about 12 to 72 hours after chest trauma. So keep that in mind as you're planning your drugs and monitoring your patient. And of course, oxygen, 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 oxygen. You may be getting flow by. You may have to put in a nasal catheter, an oxygen collar. You can see how that little doggy down there has one to help really intensify the oxygen transfer to them, or an oxygen cage. Obviously, the first one you have to maintain. The others you can, leave them maybe resting, and they should hopefully be okay for a little bit, maybe while you're prepping up your site, your surgery area. Here's a nice little puppy resting in an oxygen cage. So, how do you do a thoracocentesis? You're going to need clippers and scrub. You're going to get some kind of catheter, a stopcock, a large syringe. You may need to place a bandage over any external wounds because that may be how air is getting into the chest in the first place. So obviously you have a hole, you're going to need to cover that up. You're going to want to clip and prep, usually between the 7th and 9th intercostal space. The animal should be internosternal. And you're going to insert the needle cranial to the rib, right behind the rib, right to the caudal aspect. There is a vein, nerve, and artery. So if you go cranial to the rib, you're not likely to hit that. Remember, you want to be a little bit more dorsally in the lung field if you're trying to remove air, and you want to be at the ventral aspect of the lung field if you're trying to remove fluid. And then you'll end up using that syringe to help withdraw any fluid or air in there. Keep an example of how much fluid, keep a total volume, and you may want to test the sample for analysis.
To demonstrate how to do a thoracocentesis. Whenever you see a dyspneic cat, we always want to have the cat in flow by. We want you to be able to feel comfortable performing a thoracocentesis because it's a life-saving diagnostic and therapeutic procedure. If you have an ultrasound, we want you to be able to do a fast ultrasound to look for that presence of that large, black, hypoechoic pocket. Here, you can see we're using the fast ultrasound to identify the best location. You want to use sterile technique, a 3-way stopcock set up with a butterfly catheter and syringe, and we typically want to go in the 7th to 9th intercostal space, ideally cranial to the rib to avoid the vessels and the nerves, and evacuating as much pleural effusion as we can to make the cat comfortable. Here on repeat fast, you can see that there's still a significant amount of pleural effusion, and here we're actually saving the pleural effusion because it was quite hemorrhagic in sterile 60 ml syringes in the event that we need to auto-transfuse it. On repeat fast ultrasound, we can see there's a dramatic improvement in the reduction of pleural effusion. And again, if you don't have a fast ultrasound, still go ahead and do a thoracocentesis. Again, can be life-saving in that dyspneic cat. Most of the time, we don't actually sedate cats for this because they seem to tolerate it relatively well. Clinically, you can see that this cat is dramatically improved. It's breathing much more comfortably and is no longer breathing with a short, shallow breathing pattern. And with that, hopefully you feel comfortable performing a thoracocentesis.
Okay, so you can see how quickly that cat started to breathe better. Again, you may have to leave a tube in there with a stopcock on the end. Sometimes, depending on what's wrong with them, they continue to refill with fluid or air, so you'd have to continue to remove them off. Now, this is a little bit misleading. So few patients require immediate anesthesia. It always, at the end of the day, you're weighing what is truly going on. At best, you want to stabilize as much as possible. So again, in a respiratory issue, most likely, the first thing you need to do is stabilize, unless they're bleeding out somewhere else, which needs immediate surgery. But whenever possible, you want to stabilize them first. And this also gives you the opportunity to thoroughly work up or assess the extent of their injuries, do blood work, try to get chest rabs, abdominal radiographs, and get them more stable and give you a better idea of what is going on so you'll be more successful during your procedure.